Our door has been closed, and we might as well officially start our Community Mental Health of Ottawa County Board of Directors meeting. I think we have a quorum, which is nice. Great. And Mr. Danberg, would you like to do an invocation, please?
Thank you, Mr. Chairman. Dear Lord, we come to you on this beautiful day in May for our board meeting of the Ottawa County Mental Health. Dear Lord, we be with us as we make decisions that pertain to people with disabilities that are even beyond our comprehension of what they are going through. Dear Lord, be with these people and help us as we make decisions to help them. Guide and protect us all for Jesus' sake. Amen.
Amen. Amen. Thank you. Please note our community mental health mission and vision statements. Moving on to consent items. We're going to make a small change in the agenda. We're going to amend the agenda as follows. Under new business, we're going to remove the two suggested bylaw and operating agreement. We're just going to remove those, and in their place, we're going to add under new business the resolution. You should have all received the resolution dated May the 23rd in front of you. We're going to put that in place. That resolution is to approve the amendments to the LRE and the bylaws. So besides that agenda item change, everything else is good. We have the minutes from April the 25th, 2022. So we'll entertain a motion for approval of both the agenda and the minutes.
So moved.
Is there any discussion?
I'm just curious about the change that you made.
Mm-hmm.
Can you tell a little bit more?
Well, the corporate attorney for Ottawa County didn't have a chance to look it all over thoroughly, and
neither did I. I mean, I looked it over. I'm like, I wonder how this has changed, or I wonder what's different. So,
not a whole lot.
Okay.
Just wanted it to be more of an in a resolution type of a format, and he was able to thoroughly look it over. I think this morning.
Okay.
This morning. So that's really the only significant change.
So then, what we have here is that reflected in a resolution.
That's correct. Both those items.
The motions are reflected in the new resolution.
Okay,
yeah.
Perfect. Thank you very much. Okay.
Any other comments or discussion? Seeing none, all those in favor of approval of the agenda as amended and the minutes from April 25th indicate by saying aye.
Aye.
Aye. Those opposed, the motion carries. Public comment. Everybody looks fairly familiar, except the guy right there. No. You, Keith.
Oh, that's right.
We have
Keith.
it is you.
Oh, yeah.
Oh, nice. Glad to see.
Yeah.
Well, don't get too familiar.
Is there any public comment from the audience or online, Patricia?
I don't see anyone.
Okay. All right. Well, there's another opportunity at the end of our meeting. So we'll move right on to Anna, and she's going to be presenting a mental health millage update.
So today I'm going to talk to you about the Pathways to Better Health program. So it's our partnership with the Ottawa County Department of Public Health next door. My brain almost immediately said mental health. I'm so used to saying that. Can you pass that for me, please? So these are just the rat cards that we keep out in our lobby about this program for people to learn about, and they give it out in the community pretty regularly. So the Pathways program, like I said, is a partnership with the health department, and they have 11 community health workers who are providing short-term case management services to people in the community who have 2 or more chronic conditions, have Medicaid or Medicare or are uninsured, and might be eligible for Medicaid. They're also working with women who are pregnant. So this program started with the investment of millage dollars, and now has become a pretty good partnership with the health department. So we give about $250,000 a year towards this program to provide these services out in the community. There are other funds that we're contributing to this program that are through grants that we have received, which has allowed us to have 4 of those 11 community health workers embedded into our services here. So we have 2 who are providing services to our family services team. So that's kids through age 18, and then 2 for our adults with mental illness teams. So they're doing a lot of work getting people connected to resources in the community. So the community health workers, the ones who work through the health department and through us, are meeting with folks out in their homes, taking them out in the community. They're getting them connected to resources. They use a pathways model. So they're opening different pathways for service. That could be somebody needs housing, somebody needs a primary care provider. There are many different pathways that they can choose. So they're opening those pathways up and getting people connected to those resources. Since 2017, they've enrolled 1,434 people into the program. And just to sort of highlight how they've grown, last fiscal year, they served 553 individuals. So they've continued to really grow the program since its initial start in 2017.
And excuse me, what's the average length of stay?
It's pretty short term. I think max is like 6 months. The folks who are receiving services here at CMH with the embedded workers, those workers might kind of come in and out as needed, but it is a pretty short-term program. The folks that they're serving, this is sort of self-report. I got some interesting information from Susan Keene, who oversees the program at the health department. 45% of people who've been served report a history of mental illness. 53% report being stressed. 12% report having a substance use disorder. And then their most frequent diagnoses are anxiety, depression, chronic pain, hypertension, COPD, and diabetes. And then the pathways that they're doing. So of those 1,400 people served, they've opened 7,000 pathways for all those folks. So there's a lot of different resources then that those pathways will help get people connected to. The most common referrals that they're doing are referring folks to medical homes, dental care, medication assistance, food, financial assistance, utilities, and housing. So they're doing a lot of cool stuff out in the community. It's a really great model that's getting people connected in the community where they are instead of having to actually come in and see somebody, but they're going out to people. Any questions?
Okay, thank you very much.
Thank you.
Sure,
Distributed.
We don't have anything under old business,
Yeah.
but new business, might as well move into our service contracts, which is attachment A.
Yeah, so the first 4 on the list are actually single case agreements that we have for inpatient care at our Indiana hospitals. These range from different dates. You'll see that 3 of them have TBD next to them because the consumers are still admitted there and we don't have a length of stay in mind. So we're hoping that they transition out of the inpatient hospital. But as of right now, they're still there and we don't have a date. The next 2 are actually gym memberships through our local gyms. One's through Spring Lake and one's through the YMCA. And that's for individuals participating in the health endowment grant. And then the last one is an amendment through Rebel, and that's just to add COVID-19 flat grant and STD prevention and harm reduction grant funding for the anti-stigma windows. That was discussed, I believe, at last working.
On the first one, so single case agreement means that's one consumer.
One consumer, yep.
So for example, with neurobehavioral, I know it's to be determined, but that's an annual cost, quarter to $500,000.
Yeah, so their daily per diem for this consumer is pretty high, and these are last resort hospitals. For instance, our other local hospitals are not accepting the consumers due to high behavioral or high need that they have, and so these Indiana hospitals are what we go to when we cannot find placement local or in Michigan.
So is there, and I'm not, that, so there's no way out of it for us? I mean, I don't know how to say this. I
We
mean,
determined the length of stay along with the hospital.
okay,
The reason Troy's saying there's no end for these single case agreements is we have not determined a discharge date for some of these people. The person, the very first individual, we've been trying for months to find a residential placement for him, and we can't find one. So we are desperately looking for an alternative placement.
I'm just thinking of the hospital or the doctor out there going, ka-ching.
No,
we're getting money
no,
from Michigan here.
We,
you know?
no. We
Okay.
do what is called continued stay reviews on
Okay.
every hospitalization. And when we, along with the hospital, determine that they're ready to get discharged,
Okay.
we're making the decision whether someone stays or goes.
Okay.
Obviously, we don't do that against doctor's recommendation, but there's a whole process for reviewing that.
Okay, you get what I'm asking.
Yeah, no, they're not
Okay.
single-handedly making the determination.
Okay, okay.
How many consumers do we have in that range? Yeah.
Typically
Is that like one of our max consumers or not necessarily?
At this point, this person has been in the hospital for longer than anybody we've served in quite a bit.
And normally we do single case agreements for hospitals that we don't have a current contract with.
Sure.
And so we have a lot of local and outside of our county contracts, but we don't have one in place.
Does a single case agreement, is that partly drive the cost of it? I mean, just because you're contracting for one consumer only, or is that just the nature of the care that's provided?
It does often, it's often more expensive with a single case agreement. So we are actually working on setting up contracts with some of these out-of-state hospitals that we have previously only
So we
done.
have consumers who may need the same level of care, type of care we could bundle at some point.
Yes, we could negotiate a slightly lower rate, hopefully, yeah. Mhm.
The Spring Lake Public Schools, how many does that serve? You know,
We are doing a monthly gym membership for these individuals. Right now, we just have a cap of $10,000. So I believe, if I can remember off the top of my head, it's about $40 a month per person. So
is that like a matching grant where,
No,
just appear?
right. So what we'll pay for memberships as requested up to $10,000 for that particular gym.
Oh,
As a part of that being grant funded, are there some expected outcomes
Mhm.
that are defined in the grant?
Yep.
as a result of it?
okay. There's no further discussion. Motion is to approve the May 2022 service contracts as presented by Tori.
So moved.
Support.
All those in favor of approval of the service contracts indicate by saying aye.
Aye.
Those opposed, that motion carries. Next is attachment B, our financial report.
Good afternoon. How's everyone today?
I have to let people know that this will be Keith, probably his last meeting here. He's taken another job, so he'll be leaving us.
What?
Yeah.
Having said
Quitter.
So it's an undercover operation on
June
your
10th.
part, isn't it?
June 10th is my last day. So
Ah.
I give a month of notice.
that, we'll miss him.
Yeah.
Yeah.
Where you going?
Private sector, leaving government, going to a CFO position in Spring Lake.
Okay.
Mm,
Congratulations.
yeah, you
Yes.
bet.
Well, you're in the county at least, Spring Lake.
Yeah, close to home. I live right by there.
Yeah.
So, sorry.
No, you're not.
He is, he's
It's the
trying to be
sentiment
himself.
that counts, right?
Yeah.
So attachment B. So good news is the LRE started giving us some final payments, and it was just one big lump sum, and actually Nick worked through it. So good job, Nick, on figuring that out. That's Nick back there. He's our budget audit analyst. In case the replacement's not filled before the next board meeting and the budget approval, it'll probably be a combination of Nick and Karen that come to the next board meeting for the reports and the budget adoption in July. Okay, so keep it going. The expenses are lower than budgeted. Part of that reason is, we just did we did a budget increase for the salaries projection, the 2%, the loyalty payments and all that stuff. So the budget went up a little bit. So, the expenses haven't caught up to that. On the SU, and then so that brings us to, a net surplus of $780,000 year to date for the mental health fund. Likewise, in SUD, we see similar activity. Contractual services are a little bit lower than anticipated, so that put us at a service or surplus of 590. Jump all the way to the end of the next page. And so the millage fund, we got almost all of our millage funds in, which is good. A couple $100,000 left that haven't been collected yet. Part of that is for the different levels of taxation that occurs, that the property taxes are almost all collected. So there's surplus in there because that's the majority of the income until the end of the year. Medicaid funding, as you see, we've caught up quite a bit. It's still a slight deficit. Part of that is just the delay. There's still, there's always usually about a month lag. Are there any questions about but no concerns about, finally they started paying on time. And so we're mostly up to date. That last set
So
of
the
payments.
the millage shows 1,768,000 roughly. And as in last month,
What, which number were you referencing?
millage, the bottom corner.
Oh, so that's just an over under budget number as far as like a projected budget number to what's actual. So the year to date actual, that's green, is 1.27 million not spent of what we've collected so far.
Okay,
But then part of that is we just increased that. One, we have a lot more expenses to go yet this year, but two, we increased that by $500,000 last month. So there's a budget amendment coming that you'll see for where we talked about that extra $500,000. So we're actually scheduled to, if you look at the budget, $1.1 million. If we spend everything, that's what we'll use of the surplus.
the budget runs until September.
September 30th. Yeah. So these numbers represent 7 months. So a little over halfway.
Okay, so do you look for a surplus on our millage?
We want to see a surplus right now because we need to spread those funds out through the rest of the year for sure. So if we were close to a deficit there, we'd be eating a lot of surplus.
Okay,
So, but again, the 500,000, so half of the projected deficit is just being approved. So we'll just start to issue that. So you'll see that number go down rapidly as the requests come in for those funds.
okay.
Very nice. Any further questions for Keith? Okay. Seeing none, the motion is to approve the April 2022 financial report. April? Does that say April?
So moved.
Yeah.
Or
And Is there any further discussion? Probably not. Looking good. All those in favor of approval of the financial report attachment B, indicate by saying aye. Aye. Those opposed, that motion carries. And then we have our budget adjustment that I think you just kind of
Yep.
alluded to, right?
Just the one thing, the stabilization increase that we discussed last board meeting. So just the final approval of that to spend those funds.
Any further questions on that?
Support.
All those in favor indicate by saying aye.
Aye.
Aye. Those opposed, the motion carries. And then our bucket report.
Not much activity between the last 2 months. You see a couple percentage move back and forth from some of our members. Most went down except for Health West went up slightly in some of their projected spending. So still well within range to be over in available ISF for the end of the year.
Almost 28. Well, actually, right, yeah.
Well, they're projecting almost 61 a
Yes,
year
yeah.
end, the way it's going.
Let's see how the two combined.
Keith, what is the acronym MCO?
Managed care organization was the one I should be.
Yeah, and
Oh,
the
yeah.
admin category.
Yeah,
So LRE and the managed care organization together, those are the administrative.
so the LRE is technically the managed care division. They subcontract, if you will, some of those duties to us. But so they're the actual body that's the managed care organization.
Okay. I know I've asked you this before, but since it's my last opportunity, I'll ask
No
sort of
problem.
again. Are we looking at those administrative costs and where the state is? I mean, are we receiving the same amount to distribute to our consumers? I think about before the LRE came in.
Mhm.
That was one of the concerns around this table is the administrative costs of another layer, if you will.
Sure.
And is there a way that someone is looking at that across the state? I'm not saying necessarily here just in our county, but
Wait, so the question is someone actually looking at how much money is spent on those managed care organizations?
has
That
the state
oversee.
saved enough that that money is funneling in to cover these administrative costs that I know this is an easy way of saying it, that may have previously been covered by the state?
Well, so I mean, so you talked about previously covered by the state, so that's a good question, but you know, who's covering it? Are they still spending the same amount of money? I mean, they're obviously spending more money year over year. So there's definitely more money in the system and our rates are higher. So there's been more money in our region than there's ever been. I don't know if I can, a good way to answer that, but I don't know about the oversight about that and who's actually looking at it. I would say the state, but.
Okay, I guess, isn't Beacon overseeing the LRE too?
The Beacon contract is slowly but surely being phased out. I think they'll be finally done in July of this year. And the
Oh.
LRE is taking over those managed care functions that Beacon was performing.
Okay,
Beacon came in as a life jacket.
yes.
So Beacon does some things fairly good, but a lot of things not that hot. So correct me if I'm wrong.
Yep.
So the LRA was down to a measly, I don't know, 5 to 8 employees, and now they've whittled up to about 25, 26 employees, with the assumption that supposedly when Beacon gets phased out, those extra employees will be able to take over and run the ship properly, and not get back into the difficulties we got before. They may have to get a few more people in there, maybe up to 30, but that's what they're hoping to have happen, is to save money in the long run and not have a Beacon around anymore. Is that kind of accurate?
But I thought Beacon was hired from the state because the LRE, our area, wasn't managing our money the way they
Well,
thought.
we
we should.
actually,
Yeah, we,
we actually hired Beacon.
right,
okay,
the
to help
contract
us.
was with the Lakeshore Regional Entity and Beacon.
Okay.
And the state was sort of holding our feet to the fire
Yeah.
with trying to get some assistance because they believed at the time it was a management issue. I certainly did not agree with that. It was a
Okay.
rate issue. But as Matt said, over the last couple of years of working closely with Beacon, I think we all realized that the LRE could do the job as well as they could for less money. And so it's being transitioned back.
Okay.
So Vonnie, to answer your question, it is a kind of a complicated question, only that there's lots of factors that make up the managed care functions in the organization. But there are some statistics that the state looks at. The medical loss ratio is one of them. So that looks at what percentage of dollars is actually going towards client care as opposed to admin. And overall, the PIHPs do a pretty good job of spending most of their dollars where it should be spent on client care. We know those numbers, so we can compare one PIHP to another one. So the Lakeshore Regional Entity medical loss ratio compared to mid-state, for instance, it can also get compared to the Medicaid health plans, which provide the mild to moderate behavioral health benefit, as well as all of the other physical health care needs of people who are eligible for Medicaid. And our medical loss ratio in the behavioral health system is typically much better than the Medicaid health plans. That's one argument we're using as we're trying to prove that the bills that are out there that would change management to the Medicaid health plans, more than likely, we actually do a better job of pushing money into the system than they do. But the managed care part of the PHP system is not going to go away. Medicaid has rules that the dollars can't just go to the CMHs. So that would have to change. And I don't really see that changing. It wouldn't necessarily have to go to a PHP, but it would have to go to a managed care organization above us. So they are paying attention to it. The state, that is, the department.
We're actually off probation now, the LRE.
Oh,
Believe it or not, we're off, the lawsuit's been mildly settled. And I guess the state is saying, okay, give it a shot, LRE. And we're keeping our fingers crossed. And, we got a ways to go yet, because out of the other entities, if you have a scale of 10 and 1, we're still kind of down at the bottom. It'd be nice for the LRE to be kind of in the middle or 2/3 of the way up, but it's going to take some time for us to get there.
So Matt's right. The LRE is no longer on a month-to-month contract. I don't know if we were ever technically on probation, but you probably call it as such.
Sure
We do
felt
have-
like it.
Jim's here. You guys remember Jim from last meeting. He's from the PHP, and Mary and Stephanie are also listening in. But, I think that the LRE is positioned to do a good job. We've got some good staff. I think they know what they're doing. And there are some areas, some reports where we could improve on data submission, that type of thing, but those are processes we just have to keep working on. So
Come a long way in 14, 15 months.
yeah, come a long way in a lot of years too. It's been a rocky
Thank
road
you
for
for
the
your hard
LRE.
work and your diligence on this. I imagine At many times you were ready to say, I'm out of here. I'm done.
Oh, I think everybody in this region probably said that at one point in their lives.
Well, I think the resolution is coming up later is a reflection of the LRA trying to tighten things up and go through those bylaws, go through the operating agreements and make sure that it's together and that there isn't reason to, doubt it. So anyway, we'll get to that when we get to that, I guess. So where are we? Bucket report?
Yeah, any other questions?
Any other questions?
I have a comment.
Oh, yeah.
And my comment is just thank you Pete, for the work that you've done. I think when I think about, a couple of things, how you pulled our report together in a way that really, I think it's very readable and works well.
Yep.
And also sharing the bucket report each month has been helpful. Thank you for your work.
We like all the green. Started off with a lot of red and now you're finishing
Yeah,
up with
see, you're
just
finishing
one little
on
itty
top
bitty
of
yellow.
And we're all settled for 21, so clean slate going into 22.
Thanks for your comments. Ryan. So, moving on, new business. We have the resolution in front of you. And if you kind of take a look at it. Each one of the CMHs has, I think, correct me if I'm wrong, I think there's 2 CMHs that have approved it so far. And
That's my understanding as well.
there's 5 of us, right? So we're about halfway there. So is there any, do you want to summarize or you want to say anything regarding this resolution?
Yeah, sure.
If you would,
So,
please.
as Matt said, we had a chat with Doug Van Essen, corporate counsel. He suggested we do this resolution as opposed to the separate motions, but the language is the same, just been transferred to the resolution. I mentioned last month, and then these were the bylaws and the operator agreement were sent out to you guys. I don't know if people had a chance to review it. The major changes in the bylaws were composition of the board. We're going away from kind of a population-based representation on the board to every CMH board will get 3 members. 2 of them can be from the CMH board. One of them has to be a person who has a primary or secondary consumer, or some experience one way or the other with themselves or family members with a behavioral health issue.
What do you feel about that change then? Is that going to make a big difference or not?
That there would be representation. I think there's probably representation on the board currently, so I'm not sure we'll see.
No, the population change, the change.
Members or representation. Oh, I think that's fine. I think it's actually probably more fair that each CMH has equal representation. There was also some changes on who could be a board member. We had previously had contracted providers with the CMHs were able to be on the board. So these changes prohibit that from happening. The other big change is with the operating agreement and the funding methodology. We are currently and have been using a system that is 50% per member per month and 50% historic spending. This operating agreement change would have us go to 100% funding methodology that the state uses, which currently is per member per month, instead of the 50-50. We're much closer to being at a per member per month distribution as it is right now. There will be a slight loss of funds for us, and Network 180 isn't slight. It's a several $1 million change. But I feel like it's in our best interest to go towards a per member per month methodology. That's the rest of the states, PHPs and CMHs all use per member per month. So I think I'm in agreement with that as well. So those truly are the biggest changes in the operating agreement and the bylaws, and I'm recommending that we sign those.
Is it my understanding that our loss would be about 350,000? Is that somewhere in the ballpark?
In autism, yeah.
And there's still, I think to your point, Doug, I think there's still opportunity to have representation at those board meetings. So like Peg Dreisinger was one of our LRE members, and she was a provider. And they still will be able to be at the meetings. They won't be able to vote, but they'll still be able to be there and have input. So it's not like they're excluded. They just would not be able to have that same voting capacity.
Yeah, I assume that the change was made for a reason, and I don't know if that's a real substantive change or.
I think the ability to have each one of the CMHs have 3 members, so it's equal. So you're not getting the top heavy for like a 180 that has such a huge amount of demand that sometimes that can drag down others. So I think the representation is fair, in my opinion. Any other questions for Lynn? Well, this has to be a roll call vote. So Patricia will ask us individually, but we'll have to have.
Just a quick question.
Yeah.
Then do you like all the changes in here? There's something that sticks out that would say.
No, there's nothing I am concerned about at this point. Doug Van Ossen has also reviewed it. He's okay with it. So I'm fine with signing as is.
Someone would like to make a motion for approval of this mental health board resolution.
So moved.
All right, we have 2 motions and 1 support. That's pretty good.
Well, we don't really have to go.
So you want to do a roll call, please?
Yes. Mr. Brown?
Yes.
Mr. Dannenberg?
Yes.
Mr. Goldberg?
Yes.
Mr. Hopler?
Yes.
Mr. Kernan?
Yes.
Mr. Serrano?
Yes.
Ms. Vanderslag?
Yes.
Mr. Zylstra?
Yes.
Mr. Fenske?
Yes.
Motion is carried.
All right, great. Our executive director's report.
All right.
Get to tell us about vacation.
Yeah.
Okay.
Yeah,
I can do
pictures.
that after the meeting. I do. I don't have my phone. So from the state, I say this the last probably 8 months I've been coming, if not even longer. The lack of staff continues to be a very significant issue for the CMH system in general. Locally, we continue to struggle with finding, especially direct care workers. You know, the pass-through dollars have helped, but and we did rate increases for almost all of our providers. We were able to get them to a point where they could offer somewhere around $15, $16 an hour. As you can imagine, that's not cutting it anymore either, when people can work at McDonald's or Target for $19 an hour. So at this point, we haven't been asked for additional rate increases. As Keith mentioned, we did ask you last month, and you approved additional millage dollars to help support, especially our residential providers. So I'm staying in close contact with them. We have really good working relationships with our providers, and they will certainly let me know if they're at a point where they need some extra support. We're advocating at the state for not only that pass through to continue, but it really needs to go up to probably $4 an hour. And it needs to be put in our rates so that it's easy for us to use and easy for them to use as well. So there's some talk in both budget proposals of including a rate increase for them or a pass through again, but obviously nothing's been fully determined with that. I don't have any updates on the House or Senate bills. There's been no movement on them since last month. I did have an opportunity to meet with Attorney General Dana Nessel and myself and other Ottawa County folks. And I took the opportunity to let her know some of our concerns with both of those proposals. So she listened. Hopefully she went back to the governor and let her know our concerns as well. The state has been involved in a lawsuit regarding children's services. It's known as the KB lawsuit. And over the last year, they've been meeting to come up with a new, a reform of children's services. We've been hearing a lot about it, but they came out with some official documents that propose some pretty significant changes with the system for children and youth. Right now, that's just being introduced. There's lots of opportunity for discussion, but it could mean some significant changes for even the CMH system and how children's services operate within the state. So I'll keep you informed on that. If anyone's interested, I can send you the documents that they've sent us. They're pretty concise about what they're thinking about doing. And if they could make it all happen, it would be a good thing for kids and families and youth. But it will take some pretty monumental changes to not only the CMH system, but DHS, child welfare, the Medicaid health plans, schools, all really working together to create a better seamless system for kids and families. So I'll keep you informed on that. Another issue we're keeping our eye on, I've mentioned it before in the past, but due to the public health emergency, Medicaid enrollments were frozen. So nobody was discharged off Medicaid. And as you can imagine, as the end of the public health emergency gets closer and we're thinking more about it, we're also becoming concerned about what a pretty significant drop in Medicaid enrollments would look like. It could be, there's some estimates it's going to be about 13%, 15%. So we're again working with the Board Association to put some strategies in place that could, at least for the people we're serving, make sure that if they remain eligible, that they get their paperwork in and they remain on Medicaid. We have less control for people we don't serve, but the department, DHS, our partners, have promised that they're going to do their best to notify people so that those people who still are eligible remain on Medicaid. So I'll keep you up to date on that as well.
What is that population?
For Ottawa?
100, 200.
How many people might get disenrolled and not re-enrolled? Is that your question? For us, I think the estimate was around 15%. So I don't know, Keith, you don't happen to know what our enrollments are in Medicaid right now, but we can get that number for you, Doug.
Okay.
It'd be
off the total Medicaid or Healthy Michigan?
total Medicaid.
All, yeah, all across the board.
So that could easily be.
Well, Healthy Michigan more so than others because, you know, they have people don't go on and off. You know, some people with TANF and HMV and that kind of thing.
Right. It could be a substantial amount of people. It will be. And, you know, because we got our Medicaid through per member per month, the less enrollees we have, the less dollars we'll get.
Right. How many folks do we add over the last 2 years? I mean, we probably added and then
Yeah,
nobody fell off. People
exactly.
kept getting
So the
added
numbers
on.
are inflated, definitely, right now. You know what, I have a report that I'll send out to the board that talks about what the projected numbers are gonna look like.
Mhm.
It's something we need to pay attention to
And
because
the
it
state
could-
is not offering any cushion for that, or not necessarily? I mean, they have funds right now, so.
right. It won't be an immediate effect once the public health emergency is done,
Sure.
but it will be slowly phased in as far as you know, the automatic re-enrollment will stop and people will have to prove that they're eligible again.
And that happens in November, December, or is that more often for healthy mission?
Whenever they decide to kick it off,
Mhm.
it depends if they do it the normal beginning of the year time frame or if they're going to do it. Whenever they write out their way till November.
But income verification is done only once a year, right? It's not done like
Mhm.
multiple times per year.
Right.
Oh, sorry, yeah, once a year.
Okay, so if they declare that in January, and then that window is November, then you at least have that 8-9 months.
Yeah, I don't
Like
know
every
how
single
they'll do
month, they're
that.
gonna go through the rolls and say, we're gonna take people off as soon as possible.
I'm not sure how they'll do it,
Okay.
but I can try to find out for you.
No,
and
no,
let
I
you
just
know.
wondering if they,
In that report.
if we can talk to our
that
state
was sent out,
representatives.
There is a timeline that they shared in that report as well, that
Okay.
shows when they'll reevaluate. So the start date of or the end date of the PHE will start. And then they do begin to look at it a month later.
Okay.
Oh, wow.
So there's a timeline to reevaluate for the auto enrollment.
Okay.
So I think that report.
So that's something
They
we
have
should
three
talk to our
webinars,
state
but they're
representatives about
doing.
building in a cushion for.
Mhm. We'll send you that report.
Okay.
So news from the LRE, we already talked about the bylaws and the operating agreement. From CMH, we've been pretty busy. I first of all wanted to let you guys know that last month we spent some time talking about the new 3-digit number for mental health services. I think I was saying 811 and
Yep.
it's 988. So 811 is Miss Dig.
I love that.
Yeah, we all thought that.
Well,
That's all a good
and
chuckle, man.
Mary
Yeah.
from the LRE was like, Lynn, it's Miss Dig, and I didn't get it. I laughed pretty hard about that.
Miss Dig.
So it would have made sense if it was 811. Maybe that's where my brain was going, right? Anyway, it's 988. May is Mental Health Month. We've been doing some social media, posting some anti-stigma stuff as part of that month, and also part of some of our grant services that we're doing. I participated in a radio show just last week with WHTC and Zealand Spectrum Health, and we talked about why May is Mental Health Awareness Month and why it's important. Tomorrow I'm going to the Board of Commissioners to, you're going to be voting on 2 more crisis intervention team social workers and a clerk for our law enforcement liaison programs, using some of our CCBHC dollars to pay for those positions. We've already said goodbye to Keith. We have positions been posted, so I didn't say the big joke. You guys remember Joanne, but she used to say he's dead to me when someone was leaving, and I haven't said it yet to Keith, but we wish him well, truly. We need at least, well, we need 2 more representatives on on the LRE board. We talked about that there'll be now 3 representatives. Peg Driesinga was one of our representatives, and she can no longer serve. So if anyone is interested, we can have at least one more member from our board on the LRE board. So let me know if anybody would like to do that. Matt is currently on that board and got promoted to the executive committee as well, right?
Temporary.
Wow.
Peg was serving in that position.
Paid more?
No. So I did want to let you know that we continue to meet with some parent groups. There's an ongoing now residential group that has been meeting once a month. This month, we're going to be talking to one of the organizations that does some development of housing for low income and disabled. So continuing to talk about that issue because there truly is not enough housing for the people we're serving in Ottawa County. There's really not enough housing for anybody in Ottawa County, but in particular for our people, it has become very challenging to find affordable housing. Staffing has a huge issue to do with that as well, but there are more requests for residential placement than there are options. That's not just an Ottawa problem. It's a statewide problem, but it's nonetheless something that we've been spending time looking for solutions to. We also, next week, one of my staff is presenting to another parent work group about intellectual and developmental disability services for adults. So we are trying to get out there and help people learn about our services and problem solve along the way. Patricia wanted me to remind you that our next meeting will be at Fillmore due to the remodeling of the administrative side of this building. This room actually isn't going to be worked on, but we're reserving this for staff who need a place to sit and hoteling. So there won't be a lot of room in this particular room. It might have to be June and July, but cross your fingers that it doesn't take too much longer than that. So that's all I have.
Any questions for Lynn or your own general information, comments, meetings attended? How's the bird hunting?
That was some really good articles in the Tribune on the CIT.
Yeah.
Oh, yeah.
You know,
Yeah.
well written.
Yeah. The Holland Sentinel too.
Yeah.
Seeing none, this is our second opportunity for public comment. So if there's someone from the public who'd like to address the board, please limit your time to 3 minutes and give us your name. Is anybody on the?
I don't think anyone from the public.
No?
Stephanie and Mary.
Do they want to say hi?
I don't think so. They're not saying anything.
Okay. All right. Seeing none, we entertain a motion for adjournment.
So moved.
Support.
All those in favor of adjourning indicate by saying aye.
Aye.
Aye. Those opposed? We are adjourned.
Sign this real quick?
Yeah, I've got you.
Okay.
She's
Thank
got an
you.
official copy.
There's your official copy.
Official copy.
I got it from before.